I'm reporting from the ESH Translational meeting in CLL, and the topic has come up: how one decides between continuous therapies and time-limited therapies in managing CLL. This is a question that is quite important both in the frontline and the relapse refractory setting. And unfortunately, I won't be able to conclude the question by citing randomized data really addressing the question from the perspective of the two different major classes of therapies that are available. On one hand, we have the BTK inhibitors that are given either alone or in combination with an anti-CD20 monoclonal antibody, given as a treat to progression strategy, meaning you start it, you stay on it until you either have an adverse event or you have progression of disease with clinical and/or molecular resistance identified. The advantages of this approach are that we have the most long-term follow-up data associated with BTK inhibitors, particularly ibrutinib. They're relatively easy to start. They're relatively well tolerated, particularly with the next generation agents like acalabrutinib and zanubrutinib. And of course, I cited earlier that we don't really have any data comparing them to the time-limited approaches. Of course, sequencing matters when you're going from one CLL therapy to the next. And we do have at least some prospective data from the relapse refractory setting saying that you could save venetoclax for the relapse setting and that there is activity and the ability to mount a durable remission. On the other hand, we have time-limited approaches, and largely the only approved approach from a targeted therapy perspective at this time is the combination of venetoclax and obinutuzumab in the frontline setting and venetoclax with rituximab in the relapse refractory setting. The advantages there, of course, is that number one, it's time-limited, which is attractive to patients. They can stop after a defined period of time. Another advantage would be that there's potential for cost savings. But there are some things that are not yet worked out. We don't have prospective data for other targeted therapies following venetoclax. It's all real-world retrospective data at this time point. We don't have a lot of data available for sequencing post-venetoclax with other ven-based regimens. The question of ven retreatment comes up. And of course, we have less long-term follow-up data with BCL2 inhibitor venetoclax than we do with the BTK inhibitors, particularly ibrutinib. And so ultimately, how one chooses is a conversation with the patient, taking into account their age, their comorbidities, their preferences, in the relapse setting, their molecular genetic profile, their life schedule. And then you can make a decision. Ultimately, whether you choose a continuous strategy or a time-limited approach, the PFS data looks quite similar. And so for most CLL patients, whether you're starting with a continuous BTK inhibitor or venetoclax, you will likely cycle to the other class at some later line of therapy. What we really need now are commitment from sponsors like the pharmaceutical industry, as well as investigators, to design trials that not only perform direct comparisons of modern targeted therapies to one another, but build in sequencing questions so that we can understand, for example, the value of sequential monotherapies versus novel combinations. The question is likely to get more complex in the future as we have BTK plus BCL2 combinations become available. And without the appropriate comparisons, we're left to make indirect comparisons between the individual studies to help guide patients' choice. It's a great time for patients with CLL. There are many classes of therapy that have been highlighted at the meeting. Unfortunately, though, we still need additional studies to further clarify how to best sequence therapies and how to make this important choice between a continuous therapy and a time-limited approach.